Okay, guys, let's talk about anxiety and the related disorders associated with anxiety. Anxiety is very closely related to depression. It works on, our neurotransmitters and that ability for us to go into that fight or flight mode from our limbic system straight to our hypothalamus that causes that sympathetic response. And we will get started with it. So anxiety is defined in your book as that feeling of discomfort, apprehension, or dread related to anticipation of danger, the source of which is often nonspecific or unknown. So a perceived threat is when you'll get anxiety. And then when does it become a disorder? Well, from what we know about our DSM-5 so far is that the fears and anxieties are excessive within a cultural context, and they're associated behavioral disturbances such as interference with social and occupational functioning. So we have to have that component too. Brief little history about it. Anxiety was first coined by Sigmund Freud in 1895, who used the term anxiety neurosis there. So what's the difference between fear, anxiety, and stress? Well, stress involves an external pressure that is brought to bear on an individual. So we can have many different stresses or stressors in our life there. I would be willing to bet nursing school is one of those for you guys right now. And fear is based off of a real threat, like in our old ancestor days of, the woolly mammoth or the saber-toothed tiger there. And anxiety is that fear response from a perceived threat. Okay, so some considerations about anxiety disorders. It's more common in women than in men by about 2 to 1 there. And it's difficult to determine normal anxiety from abnormal, such as are we living our biggest, most optimal life there, or is something preventing us from doing that? And how are we functioning as a society or within society? Are we having day-to-day struggles or intermittent struggles? When does it cross that line of being a problem with functioning? So we need to ask ourselves, is this anxiety in proportion to the situation that it is creating it? In the context of fear, then yes, it is proportional because it is a real threat. There's someone walking behind you in the middle of the night. That's where our fear response is going to take over. And then once again, how much is this interfering with our social, occupational, or other important areas of functioning? One way to assess anxiety is to use this HAM-A score, and I'll leave you the link here so you guys can click on it and see what questions a provider might ask a patient in order for them to determine if this is a normal or abnormal amount of anxiety there. They say that a good amount of anxiety is actually kind of what drives us. So we can't take all of our anxiety away, or else we won't be going to conquer all of these things in life, especially in nursing school. So we can have this thing called panic, which is the sudden overwhelming feeling of terror or impending doom. And this is the most severe form of emotional anxiety, and it's usually accompanied by behavioral, cognitive, and physiological signs and symptoms considered to be outside the expected range of normalcy. When panic disorder happens, it usually occurs in our 20s or late teens. I don't know if you guys are noticing a pattern here about the onset of many of our mental health disorders there. And the frequency and intensity of these panic disorders really varies from patient to patient or from person to person there. However, there are some risk factors which can include some genetic vulnerability, some tendency toward negative emotions, and we'll go over kind of some cognitive distortions, things that we can tell ourselves that aren't exactly true, that may be changing the way that we behave. Thoughts and turn into behaviors at that point. History of childhood abuse, as we're learning more and more about adverse childhood events. There's more and more that's coming out about how our childhood experiences how it will change the course of our behaviors there. And then there is some linking to smoking as well. So generalized anxiety disorder will be that persistent, unrealistic, and excessive anxiety and worry. And this happens more days than it doesn't for at least 6 months. So it's this chronic condition there. And then it's significant enough to impair social or occupational functioning. This is associated with muscle tension, restlessness, or that kind of generalized feeling that you're on edge there all the time. Some etiology of panic and generalized anxiety disorders. There's some different theories out there. One is the psychodynamic theory, which has us believe that we, for some reason, have created these ego defense mechanisms that have kind of turned into hyperdrive and be ineffective. So our means of coping are not healthy. Then we have this cognitive theory, which means that we have faulty or distorted or counterproductive thinking patterns. And then anxiety is an outcome of that distorted thinking. And we'll go over that in the next slide. Some biological theories, some genetics. This happens to be supported by family studies, which is not as significant as these twin studies when they do the identical twins. Having said that, like families can, is this a nurture or a nature thing? So families can exacerbate these conditions just by their nature within that family unit there. So we also have some structural studies that show that there is some abnormalities with these individuals in their temporal lobes, as well as their amygdala, and especially our hippocampus, which is that ability to store information and to be used for later. When that is ineffective, can you imagine how well we are not able to cope? And then there is some evidence of increased norepinephrine and then decreased serotonin and GABA with these conditions. The book also highlights some phobias, which I won't go too much over, but basically it will highlight agoraphobia, social anxiety. Agoraphobia is that fear of leaving your house or being amongst public or being amongst our crowds here. And so a person will oftentimes just stay at home. They usually avoid these situations where they're actively avoid these situations where they're that are causing the fear there. And then our social anxiety could be, the fear of public speaking, and once again they just get avoided. So that's what this happens to be. So you may result in avoidance of the situation. So if we fear heights or airplanes, we may not fly. If we fear clowns, we're gonna stay away from the circus. So here's the information here about cognitive distortions, and it's kind of eye-opening, the things that we tell ourselves, because I'm guilty of one or two of these myself. And so the way that we talk to ourselves really changes the way that we behave, or how we perceive something, or how we act, right? So one of those is all or nothing thinking, which means you look at things in absolute and black and white categories. Another is overgeneralization, which means you view a negative event as a never-ending pattern of defeat. This always happens every time I get a little bit of money. My car goes, has a mechanical failure. Mental filter, which means you dwell on the negatives, discounting the positives. So you insist that your accomplishments or your positive qualities don't count for anything. You might jump to conclusions. One of those is mind reading, where you're assuming that people are reacting to you negatively when really there's no evidence of that happening. And then fortune telling, which means you arbitrarily predict that things will turn out badly. Then we have magnification or minimization, which means you blow things way out of proportion or you shrink their importance. And then we have emotional reasoning. So you reason from how you feel. Like, I feel like an idiot, so I must be one. These are all things that we say to ourselves that can really impact the way that we behave, right? Then we use should statements, like you criticize yourself or other people with should, ought, must, and have tos. We label ourselves. Instead of saying I made a mistake, you just say I'm a jerk or a fool or a loser. And then there's personalization and blame. So you blame yourself for something that you weren't entirely responsible, or you blame other people and deny your own role in the problem. So obsessive compulsive disorder, we have to have both obsessions and compulsions for us to be diagnosed with obsessive compulsive disorder. So obsessions are these intrusive thoughts that are recurrent and they're stressful. Although they are recognized by the individual as irrational, they continue to be repetitive and cannot be ignored. So the patient or the person with obsessive compulsive disorder is very well aware that these thoughts are irrational, but they can't avoid them. And then the compulsion will be a repetitive ritualistic behavior or mental act that the individual feels driven to perform, which are intended to reduce the anxiety associated with those obsessive thoughts. And then once again, it has to be significant enough for them to have an impairment of their work, social, or home life. There are two ways a person can act upon their obsessions, and one is a passive avoidance, or just a simple avoidance of the situation. So if you know that something is going to cause the anxiety, you will kind of passively ignore that area. And then active avoidance is that one that kind of we will really think of when we think of OCD, and that's where you engage in a behavior that provides that relief from that anxiety. Hand washing happens to be one of them, right? So obsessive compulsive disorder affects men and women equally, and once again, it typically occurs in adolescence or early adulthood. And I'm going to pause this just for a moment so I can get you guys on the screen for a YouTube video. Okay, so what you guys are ready to see is a panic attack associated with obsessive compulsive disorder. So you will see both in motion.
Come on, really, man. 1, 2, 3. Come on. Take your shoes off. Why? Take your shoes off or don't come in. You take them.
I'm taking them off. All right, come on, man. I'm taking the shoes off. Give me a break over here. Jesus Christ. Oh, God, what is that smell? What, you getting attacked by Mr. Clean? Come on. No window, buddy. No windows. Okay.
looking for something, sucker? My partner, have you seen him? He's been missing most of the week. Tall, good-looking guy. Would you watch the road? You're spilling food in.
What?
You didn't take your shoes off.
Okay, I'm taking the shoes off. Okay, buddy, I'm taking them off. See, they're off. Shoes are off, okay? There you go. Oh, man, you are bad. You take your nose?
Spilling drain bags.
Oh, Mike, man. Call me, so. You got me shit.
That's what I said.
Okay, here we go.
All right, come on.
Let's go. Just breathe. Okay, just keep breathing. Breathe. Okay. Okay. There you go. What? Okay. Food's gone. Food's gone. All the food. Okay. Listen to me, Roy. You listen? I want to make a couple of calls. My aunt saw the shrink after her divorce. He really helped her. He's a good guy.
Frank.
Hey, Roy, you need to see someone, okay? Don't think I'm doing this just for you. You know, you got money. You can retire. I got car payments, man. I don't need a partner. My heart goes out to you, but this is it now. I got to make some money.
Would you wipe that thing off when you're done with it? I have to be serious. Wipe it off.
You like that? What's that? Okay, I'm sorry. Okay.
Okay, so as you can see there, that's a good example of Nicolas Cage's character having some intrusive. He's not able to passively avoid these stressors that are going on. So he's going to be doing a probably manifest to compulsions, which he did. Okay, so a couple of things that we can do. Excuse me. So let's talk a little bit about some other anxiety disorders. Believe it or not, these are all anxiety driven. Despite what you might think there. So one is body dysmorphic disorder, which is where we turn one flaw or even perhaps not a flaw about ourselves into a strong kind of obsession there, have some fear based on that, like everybody's looking at you. Another one is basically a manifestation of a compulsion, which is trichotillomania or hair pulling disorder. You need to be careful with these people that they're not, these patients, that they're not swallowing their hair. This can lead to what is known as a bezoar in the stomach, a collection of hair there. And then hoarding disorder is a manifested anxiety disorder. So several nursing diagnoses that can happen with these anxiety disorders. One is panic, anxiety, fear, ineffective coping, ineffective pulse control, social isolation, ineffective role performance, powerlessness. In the theory world, there's a few things that we can do. And one is called implosion therapy or flooding. And this is where a therapist who's experienced and has a good rapport with the patient will flood the patient with fear-invoking content until the patient relaxes, and the patient will physically be stressed out until the very moment that they relax. So they don't really recommend this one, but it does happen to help a little bit more with like our anxiety disorders. So that's why it's on here. Other therapies that can be used are a low risk situation that introduces those fears. So let's say we're afraid of flying. Low risk thing will be, going on an airplane and then maybe doing a little flight simulator. And so we kind of slowly introduce that patient to the fears there. I did add it in some fears that some people might have against COVID-19. So what can we do for this patient other than create a really good therapeutic relationship, right? For our patients with obsessive compulsive disorder, nurses need to limit sometimes those compulsive acts, but they shouldn't interrupt the compulsive acts. So they'll say, it looks like you wash your hands 40 times today. Tomorrow we're going to make it 35. We're going to teach the client to use alternative coping methods to decrease that anxiety, or kind of ways to avoid these things, to begin with, using passive avoidance there. The patient's behavior may be frustrating to staff and family members. It doesn't seem like that you're on the same team as far as your therapies and ultimate goal goes. So it can be really frustrating for the nurse taking care of them, but they need to make sure that they are consistent in their approach to care. They're going to assess the needs of the patient very carefully. They're going to provide an environment that has structure and predictability, and that is used as a strategy to decrease anxiety. And then you're going to help eliminate the risks associated with like the use of drugs and alcohol, which may exacerbate these things. We'll talk about lows a little bit more during our lecture time. That's all I got for you. Thanks, guys.